Thoracic spine and rib cage, evidence-informed physical therapy. Key concepts and clinical applications. Introduction. Thoracic spine overview. Thoracic spine pain is less common but as disabling as cervical or lumbar pain. Often linked to musculoskeletal disorders, including neck, shoulder, and elbow pain. Important to understand thoracic spine's role in global body mechanics. Anatomy overview. Key anatomical structures. Spinous processes, easily palpable, used as landmarks in physical exams. Transverse processes, lateral to spinous processes, form joints with ribs. Rib angles, important for muscle attachments, palpation can indicate dysfunction. Scapula landmarks, T3 aligns with the spine of the scapula, T7 with the inferior angle. Clinical biomechanics. Movement patterns in the thoracic spine. Flexion and extension, limited compared to cervical/lumbar regions due to rib cage. Side bending, gradual increase from T1-T12, rib cage adds stability. Rotation, greatest in upper thoracic segments, decreases towards lower segments. Rib cage influence, restricts thoracic motion but provides essential stability. Pathomechanics. Common thoracic motion impairments. Flexion impairments, common in upper/middle thoracic spine, T3-T7. Extension impairments, notable at the cervicothoracic junction, C7-T2, and lower thoracic spine. Clinical impact, motion restrictions often linked to pain and functional limitations. Interventions, focus on restoring mobility through manual therapy and exercise. Thoracic pain referral patterns. Pain referral in the thoracic region. Facet joints, pain can refer 1 to 2 levels below the affected joint, sometimes to the chest wall. Discs, herniations can cause local pain or refer to the chest, abdomen, or back. Clinical application, understand referral patterns to differentiate thoracic from visceral pain. Differential diagnosis. Screening for serious pathologies. Red flags, history of cancer, increases suspicion for metastatic disease. Unexplained weight loss, possible indicator of systemic illness. Night pain, could indicate a serious underlying condition. Potential diagnoses, metastatic bone disease, common in patients with a history of breast, lung, or colon cancer. Spinal infection, look for fever, recent surgery, or intravenous drug use. Visceral causes of thoracic pain. Understanding referred visceral pain. Myocardial ischemia, presence as chest pain, may radiate to the back. Peptic ulcer, boring pain from epigastric area to the thoracic spine, often related to meals. Cholecystitis, pain in the right upper quadrant, often after a fatty meal, can refer to the right scapula. Clinical relevance, always consider visceral causes when thoracic pain lacks mechanical features. Thoracic spine disorders. Common thoracic spine disorders. Thoracic degenerative disc disease, common but often asymptomatic, pain usually nonspecific. Thoracic disc herniation, rare, can cause localized or referred pain, sometimes with radicular symptoms. Nonspecific mechanical thoracic pain, majority of thoracic pain falls into this category, treat with manual therapy and exercise. Thoracic spine and rib cage dysfunction. Impact of dysfunction. Pain and mobility. Thoracic spine dysfunction can alter global spine mechanics, affecting posture and movement. Case examples: patients may present with symptoms that seem unrelated but are rooted in thoracic dysfunction. Treatment focus: restore mobility and function through targeted interventions. Manual therapy interventions. Thoracic manual therapy techniques. Thrust manipulation, quick, controlled movements to restore joint mobility. Non-thrust manipulation, gentle, sustained pressure, ideal for patients with contraindications to thrust techniques. Evidence base, Strong support for the use of manual therapy in treating thoracic spine dysfunction. Exercise interventions. Exercises to improve thoracic mobility. Thoracic extension exercises, essential for countering kyphosis, especially in older adults. Rotation exercises, important for maintaining and improving thoracic flexibility. Combination with manual therapy, exercises enhance and maintain gains from manual interventions. Case Study 1, Middle Thoracic Pain. Patient Overview. Presentation: 47-year-old female with thoracic pain post-lifting activity. Key findings: limited thoracic rotation, pain with trunk movements, hypomobility at T8 T10. Diagnosis: mechanical thoracic spine pain, with considerations for metastatic disease due to cancer history. Treatment plan: focus on restoring mobility, educating on safe activity resumption. Case Study 2, Thoracic Spine Mobility Impairment. Patient Overview. Presentation: older adult with significant kyphosis and thoracic stiffness. Key findings: reduced thoracic extension, pain on palpation, and functional limitations in daily activities. Diagnosis: age-related thoracic hyperkyphosis with associated mobility impairments. Treatment plan: emphasize extension exercises, postural correction, and manual therapy. Special considerations: aging in thoracic spine. Age-related changes: decreased mobility, common in older adults, associated with increased kyphosis. Kyphosis and falls: increased thoracic kyphosis linked to a higher fall risk. Exercise as prevention: strengthening spinal extensors and improving flexibility can mitigate these risks. Neural dynamics in the thoracic spine. Neural considerations in thoracic pain. Sympathetic chain lies close to rib heads, can be affected by thoracic dysfunction. Intercostal nerves can be implicated in rib fractures or post-surgical pain syndromes. Neural mobilization techniques like the slump test can help assess and treat neural involvement in thoracic pain. Clinical outcome measures. Tools for thoracic spine assessment. Numeric pain rating scale, simple measure of pain intensity. Patient-specific functional scale, assesses function in specific activities relevant to the patient. Thoracic range of motion, ROM tests, quantify movement limitations and guide treatment. Patient education and counseling. Addressing patient concerns. Imaging findings, educate that degenerative changes are common and not always linked to pain. Activity resumption, encourage graded exposure to feared activities to build confidence. Self-management, teach exercises and postural corrections for daily practice. Current evidence and research. Recent findings in thoracic spine treatment. Manual therapy, strong evidence supports its use in thoracic pain management. Exercise therapy, essential for maintaining gains from manual therapy and preventing recurrence. Research gaps, more studies needed on the long-term effects of combined interventions. Conclusion. Key takeaways. Holistic approach, combine manual therapy, exercise, and patient education for the best outcomes. Importance of the thoracic spine, central role in overall spine mechanics and global movement. Stay updated, continue learning from the latest research to improve patient care.